Thank you so much for having me, and forgive me for being so much casual. I just lost my luggage, so forgive me for that. So today, because we have only 5 minutes before the session is closed, 4 minutes, 10 minutes. Okay, thank you. So I have nothing to disclose. And just before we start, I would like to remind you with the huge burden of the heart failure. As you know, that 1 in 5 people will get heart failure in certain time in his life. Number one cause of hospitalization for population over than 65 are they have got hospitalized for heart failure. Also, 30% will be readmitted after 90 days of discharge, and 30% will die after 1 year of hospitalization. So these are really freaking numbers, like just to show us how bad is it. Also, 50% will die in 5 years. Okay, so not only that, it's not only the death, it's also the quality of life. You see that the heart failure is affecting the quality of life significantly for patients, and up till now, with all the medication we have, is still unmet need for those patients. If you see the mortality rates, like if you see cancer, breast cancer, Hodgkin, non-Hodgkin, colon cancer, leukemia, they are all less in 5 years, less mortality rates than heart failure, which is 48% mortality. So this is that's just want to show you how bad the disease that we are dealing with. This is number one. Number two, if you look to the natural history of heart failure, you can see after every hospitalization, there is a little bit of stability and then dipping again. And then during this is deterioration, and they lose some of the ejection fraction, but it will never come back to its normal. It's getting like step down, deteriorating to hell. So now, heart failure, what we have here, we have, as you all know, reduced ejection fraction with less than 40%, or HFpEF, or preserved ejection fraction, more than 50%. And this is in the middle, the 41 to 49 is a mildly reduced ejection fraction. So is it all the same? I don't believe so, because you have also the improved ejection fraction, which means that someone who had ejection fraction less than 40 and with medication improved 10 points, which made him up to more than 40. So is the one with mildly reduced, it's the same one like is the improved? I doubt. We cannot do. So we will see now. And this is just the global trend of the heart failure. How is it? And today we will focus only on the mildly reduced. If you see here, it looks like a small sector, but the truth, it is not small sector. It's just investigated and undermined that I believe it will be way bigger than it is shown in the global heart failure trend. So many studies didn't look at it, except for a few studies. One of them, one of the biggest in the world, the liver study, okay, look at this category, the mildly reduced and improved ejection fraction, and it is largest to date because they hired or they recruited more than 6,000, and they did randomize them SGLT2 inhibitor versus placebo, and then what we found here that there was significant improve and 18% relative risk reduction when the arm of SGLT2 inhibitor or the empagliflozin, or dapagliflozin, and they saw it up to even up to 13 days after randomization. So it is early and in the significant relative risk reduction. But then when they look to the one with the mildly reduced, they look at two things. The one was mildly reduced, ejection fraction less than 49, and also they look to the improved, because those with a prior ejection fraction less than 40. And they found that both groups, when they compared both groups, they found that both groups significantly benefit from having SGLT inhibitor regarding the cardiovascular death, regarding heart failure hospitalization, and regarding the heart failure visit to the ER. So it is consistent benefit in patient with heart failure and with improved ejection fraction to have SGLT inhibitor. And why I'm saying that, let me just also because Emperor Preserved did the same, but without looking at the improved. They looked only to the mildly reduced ejection fraction as a whole, they didn't define them as one improved and one not. So, and also they looked to the cardiovascular death, the heart failure hospitalization, and they looked to the quality of life and the kidney. So, and they found that the whole population who received SGLT inhibitor benefit versus placebo, and especially the group of from 41 to 49. If you see here the dots, it shows you, so that the more away from the line, it tells you it's more benefit. So the most benefit group in this study was the mildly reduced ejection fraction. And here also, they showed the mildly reduced versus the HFpEF, both benefit, but the mildly reduced even benefit more. And here they showed that they concluded that the empagliflozin reduced the primary composite endpoint for cardiovascular death and heart failure hospitalization for 21% in the whole population of the study, but 29% for those who had mildly reduced ejection fraction, and 17% only for the HFpEF. Okay, and also regarding AGFR, he showed before, so there was significant improvement. Here also the quality of life, the one who received SGLT inhibitor, the quality of life was improved versus placebo, and the quality of life was way better for the mildly reduced than the HFpEF. Also, the other studies, when you combine the Paradigm and Paragon for ARNI, okay, they look at male and female. And if you look to from 40 to 50, you will find that they did benefit, but not that much. So this led to the 2023 guidelines in European society. And as you all know, mrEF, there is no doubt. Okay, the 4 pillars, ARNI, beta blocker, SGLT inhibitor, MRA. And then when it comes to HFpEF, it's SGLT inhibitor and diuretics and treats the cause, and all class 1A. Now, when we look at the mildly reduced, so sometimes it will be confusing for some people because, okay, now what are you going to do? You have class 1A for SGLT inhibitor for the diuretics, but class 2B, which is maybe, you don't know, that you can use ARNI, may not, AMRA and beta blocker, is 2B. Okay, so now the question for you, you have someone who is ejection fraction 41 to 49. What are you going to do? Are you going to, what, the 4 pillars? Or you just give diuretics and SGLT inhibitor because it's class 1A? Or are you going to stop, the patient come to you, oh, ejection fraction 45. No, we'll stop this medication because it's not perfect, it's 2B. So they did look at that also in the TREAD trial. So in the TREAD trial, they tried to stop the medication source for the dilated cardiomyopathy, significant group, yes, but they just tried to stop the medication for 6 months. So they just randomized people with improved ejection fraction to normal from HFrEF to normal, and 50%. So they stopped the medication for one group, and they leave the medication for the other group. For AXA, after 6 months, so they do it over 6 months, and after 6 months, what they found? They found significant event. 44% of the patient who stopped the medication deteriorated and relapsed. So the recommendation, please do not stop the 4 pillars. Even you like mildly reduced, yes, but not stop, or normal, don't stop the medication at all because 44% will deteriorate. This is one thing. So just to stick to the time. Now, we know a lot about HFrEF, and we have the 4 pillars. Okay, and we have BEF. We need more studies, yes, but at least we have the SGLT inhibitor and we have the diuretics as class 1A. When it comes to mildly reduced, So please, until we have more information, because it's only a few studies looked at this. So do not brush all the mildly reduced with one paint that they are all one color. You have the improved, you have the one who never had mrEF, they just was 60% and now they are 45. Okay, so until then, what we're going to do, we will follow the guidelines with this, that, like we go for SGLT2 inhibitor and diuretics, yes, but case by case, you have to consider the beta blocker, the SGLT2 inhibitor, and the mrEF, because I believe soon the 2B will be 1A very soon, in a few years. Soon it means few years. But the one with improved, please do not stop the 4 pillars. You stick on it, even the patient is asymptomatic, because there is 44% for chance that they will relapse, and you never know if they will come back again to normal ejection fraction or not. So thank you so much.